Thank you to the conference organizers for inviting me to present here in Hong Kong. I wish I could be with you in person. I'm Andrew Armstrong, a medical oncologist here at Duke University. I'm a professor of medicine, surgery, pharmacology, and cancer biology, and I've been invited here to talk to you for the next few minutes about first-line therapy in men with mCRPC, emerging data on AR PARP inhibitor combinations. These are my disclosures. Let's first talk about frontline therapy with monotherapy with AR inhibition. We've known for many years that survival can be extended with both abiraterone and enzalutamide from the Cougar 302 and PREVAIL trials, that the median survival ranges around 3 years for most men in contemporary practice, and that the real-world data supports that these men are not doing as well as in clinical trial settings, where the real-world experience, even in modern eras, supports about a 2 to 3 year survival. Thus, in a best-case scenario, men with mCRPC in this first-line setting tend to have a survival around 3 years, obviously with great heterogeneity based on known prognostic factors, but overall survival remains significantly shorter in real-world practice. Treatment evidence in mCRPC patients are highly evolving, and we're moving more towards precision medicine approaches with the approval of olaparib for BRCA2 and other homologous repair deficient patients in the mCRPC setting, with VISION study positive and PSMA positive mCRPC in the third-line setting with the availability of cabazitaxel radium. But many of our trials still support a survival of around 3 years from this first-line interval. A hard reality is that many patients in the community, both in Asia and in the United States, are not receiving multiple lines of therapy. That about 77% do receive first-line therapy, but about half of those patients go on to receive second-line, and it's a diminishing rate of return that only 16% in the community are receiving 3 or more lines of therapy. And this is just a harsh reality based on patient comorbidities, age, and disease progression, which can be a life-threatening event. We know that sequential use of an AR inhibitor, such as Abi after Enza or vice versa, results in very little patient benefit, that most patients fail to respond either with a PSA decline or objective response, and that progression-free survival is around 3 to 4 months, indicating that this is not an effective standard of care, and that switching to a different mechanism of action, whether that's olaparib or cabazitaxel or PSMA lutetium, is much more effective than switching to something in the same class or mechanism, such as a ligand binding domain AR inhibitor, which is really not as effective. We know that many men with advanced prostate cancer will harbor mutations in DNA repair enzymes, such as homologous repair enzymes, particularly BRCA2 mutation. You can see the prevalences of tumor on the left, or germline mutations in these HRR genes. About 72% of men do not harbor these, but almost a quarter of patients will harbor either tumor or germline mutations. And now NCCN and most international guidelines recommend germline testing for all men with advanced prostate cancer, starting with localized high-risk disease and upwards to node-positive and metastatic patients. And then in selected patients with even lower-risk patients based on a suggestive family history. As we move into talking about PARP inhibitors, it is important to realize that each PARP inhibitor has different properties, just like different AR inhibitors have different pharmacologic properties. There's different measures of how PARP inhibitors bind to DNA and trap the enzyme onto the DNA. You can see differences in potency and differences in toxicity. In the lower left, you can see differences in secondary pharmacology and off-target effects, with olaparib probably having the fewest off-target effects as compared to niraparib, for example. And you can see different therapeutic indices in homologous repair proficient versus deficient cells, with a very wide range of differences in activity between proficient and deficient cells for most of these PARP inhibitors, but some differences among them. You also see differences in partitioning. This is where the drug accumulates, for example, in the plasma or the bone marrow, which may lead to some off-target toxicity, such as anemia or thrombocytopenia, with, again, olaparib having very different profiles than rucaparib or niraparib and talazoparib. Olaparib is approved worldwide for patients with advanced prostate cancer. This is based initially on the monotherapy trial, phase 3 study called PROfound, which enrolled in cohort A men with BRCA1, 2, or ATM mutations who had failed a potent AR inhibitor and were randomized to a second AR inhibitor, which we now know to be an ineffective standard of care, or olaparib. And you can see a major benefit in delaying progression-free survival and overall survival on the right with olaparib in this cohort A group of patients. If we zero in on the BRCA1/2 mutation carriers, which are driving the vast majority of this benefit, you see a hazard ratio of 0.22 for rPFS and 0.63 for overall survival benefits. And olaparib in Hong Kong is approved for MCRPC men who are progressing on a novel hormonal agent with or without prior dose of Taxol. And you can see that the vast majority of these patients are having a robust PSA decline, an objective response, and having reductions in circulating tumor cell counts, and this is translating into better survival. There is activity in patients with non-BRCA mutations, but it's lesser so. You see many patients can still have reductions in PSA or objective responses, even with ATM, CDK12, and other HRR mutations, but it's to a lesser degree than BRCA2. And it's very similar, actually, to what you see with another AR inhibitor. So in these subgroups, we did not observe significant superiority of olaparib over a second AR inhibitor. So why are we thinking about moving a PARP inhibitor into earlier settings? The two main reasons are that AR itself regulates homologous repair deficiency. And so when you block AR, you create a homologous repair deficiency state, much like how we use androgen deprivation therapy with or without potent AR inhibition to sensitize tumors to the killing effects of radiation. And we see improved survival with radiation. The same concept can be applied to inducing a DNA repair defect and making a cancer susceptible to PARP inhibition. So it's an induction of that synthetic lethal relationship, even in tumors that are not germline or somatic mutation carriers with homologous repair deficiency enzymes. The second reason is that PARP enzymes themselves have some DNA repair independent mechanisms by activating the AR pathway. They act as pioneering or cofactors that enhance AR binding and AR dependent transcription. This combined effect is the theoretical basis for the PROPEL study and many other combination trials. These are some seminal papers, if you'd like to go back and look at them, from 2013 and 2016, from major papers describing the role of AR and its importance in DNA repair. But basically, preclinical studies have suggested that an AR inhibitor and a PARP inhibitor have synergy, even in tumors like in these models that lack the DNA repair deficiency. And you can see here that the cell kill, the number of proliferating cells, is much more enhanced with the combination than either one alone, and the cell growth in vivo and mouse models is enhanced with the combination. This led to a smaller phase 2 randomized clinical trial of men with MCRPC post-dose of Taxol who received abiraterone. They were AR therapy naive, or abiraterone plus olaparib. As you can see in this overall study, progression-free survival was substantially improved by about 5 months over this active control. Well, what was really interesting is that patients that did not have any detectable alterations in DNA repair enzymes, the hazard ratio for rPFS was improved at 0.54, suggesting that benefits were there independent of the presence of germline or tumor HR mutations. Now, this has led to multiple phase 3 trials, and we're going to talk about a few of these tonight. The PROPEL study is abi and olaparib, where both doses can be given at full tolerated doses compared with an abiraterone control. We have TALAPRO-2 that just had a positive press release, but in this study, talazoparib had to be given at half the dose. We've had the MAGNITUDE study that has been presented, but in this study, while abiraterone was given at full dose, the niraparib had to be given at a reduced dose due to toxicities. And then we have an as yet unreported study called CASPAR, which takes patients who have already had an AR inhibitor and then gave them rucaparib plus full dose enzalutamide. You can see this laid out in the schema here, that we're really moving these combinations now that we've seen positive results into earlier and earlier settings with some ongoing hormone-sensitive trials now, TALAPRO-3 and Amplitude, and some positive results now validating the results from PROPEL and extending these results to other AR inhibitors and other PARP inhibitors, such as the TALAPRO-3 trial, as well as the TALAPRO-2 trial and the TRITON-3 trial. Let's just talk about each of these. So in the MAGNITUDE study, we saw, somewhat mixed results, but that the reason for this might be due to the fact that a higher dose of niraparib was too toxic to be given in combination with AbbVie, as you can see in this phase 1 study. So that led to a dose reduction from 300 to 200 that may have compromised some of the efficacy. In TALAPRO-2, we did see that talazoparib had to be given at not the full dose because of drug-drug interactions, and that led to some more significant side effects that had to be reduced. Again, we haven't seen the results of the larger talazoparib phase 3 trial. With the PROPEL study, we did measure both abiraterone and abiraterone pharmacokinetics of their metabolites, as well as the olaparib pharmacokinetics, and we saw no changes in the distribution of either AbbVie metabolite, or olaparib pharmacokinetics with each other as compared to historic monotherapy data. So the phase 3 study was called PROPEL, and this was a much larger study of 796 men that were first-line MCRPC, no prior NHA. Docetaxel was allowed in the metastatic hormone-sensitive setting. All patients had an active treatment of abiraterone prednisone with either a placebo or olaparib at the full monotherapy dose. The primary endpoint was rPFS, which, as I mentioned, is a clinically significant endpoint because we manage patients this way, and many patients don't go on, as you saw in the community data, to even receive second or third line therapy, and progression can be a life-threatening event. We have measured overall survival, and this will be updated later this year, and are reporting on this as a key secondary endpoint. We're also reporting on many other secondary endpoints. As has been published in the New England Journal of Medicine Evidence, we showed that the main primary endpoint was met. rPFS was significantly delayed either by investigator assessment, the primary endpoint, by 8.2 months, or by blinded independent central radiographic review by 11.2 months. So hazard ratios of around 0.61 to 0.66, all meeting the primary endpoint of the study, which was thus a positive study. And these are clinically significant delays in progression or death by 34%. We see that at DCO2, which is the second update, which was presented in Paris just a few weeks ago, that this data was maintained with a very similar hazard ratio, and again, about a 9-month extension in rPFS. There are all subgroups benefiting from the addition of olaparib, regardless of age, geographic location, baseline PSA, and pattern of spread, as well as functional status. You do see some heterogeneity based on HR mutation status, but the hazard ratio for patients even without mutations in these DNA repair enzymes did not cross 1. So none of these subgroups crossed 1 in terms of the rPFS benefit. When we look at the Kaplan-Meier plots, again, you do see a greater magnitude of difference for the HRRM positive patients with a near doubling in the progression-free survival, hazard ratio 0.5, but still a clinically significant improvement in rPFS by about 5 months in patients without detectable alterations, either by cell-free DNA or tumor DNA, which was collected on all patients. In the BRCA2 patients, we see a substantial hazard ratio of 0.23. This is a major separation in these curves. But even in patients that are not BRCA1/2 carriers, we see again about a 5-month improvement in rPFS, which is still clinically significant with hazard ratios that do not cross 1. When we looked at overall survival, we're only at about 40% maturity. These patients continue to be alive and doing well. The p-values continue to inch closer to a positive threshold of 0.05. And the hazard ratio right now is 0.83, favoring the combination, but not yet clinically significant. And we again expect these updated results to be in the coming year. The overall safety profile of PROPEL suggests that most patients can tolerate the full dose of both of these drugs without a dose interruption or a dose reduction. We do see that about 21% of patients do require a dose reduction in olaparib, usually due to anemia, and no differences in the discontinuation or reductions in abiraterone. Very similar proportion of patients with severe adverse events and deaths due to adverse events. I would point out that we did have one case of MDS AML that was identified, but again, the early use of a PARP inhibitor in this setting has not led to a major increase in this risk of myelodysplasia. In other adverse events, we do see an increase in pulmonary emboli, as I mentioned on the earlier slide. Anemia is probably the most common grade 3 toxicity requiring transfusion in about 15 to 16% of patients treated with the olaparib group. In this tornado plot, you can see a slight increase in fatigue as well as other hormonal side effects that are expected for abiraterone. Conversely, the MAGNITUDE study was a genomic stratified study, again, a first-line MCRPC study in patients that were AR therapy naive. But here, there were two cohorts to analyze, a 600-patient HRR negative cohort that was negative, and then an HRR positive cohort that was positive. Let's go over those results. For the wild-type patients that had tumor testing and lacked HRR mutations, we saw a hazard ratio of 1.03, and this is again for rPFS, so very different than in the PROPEL study, indicating no benefits for niraparib at the doses used in delaying progression. For the BRCA1/2 patients, we do see a substantial delay in rPFS of hazard ratio 0.53, and this is again by central review or investigator, but not nearly as substantial as that which was observed in the PROPEL study, where again it was about 0.23 for these same patients. In the HR positive patients, which include BRCA2 as well as other HR genes, the hazard ratio was 0.73 with about a 3-month delay in rPFS. There are some heterogeneity of the results, particularly BRCA versus non-BRCA for niraparib, and indicating that most patients with non-BRCA are not benefiting in terms of any clinical delay in radiographic PFS with this combination. We do see heterogeneity in this study based on prior taxane in terms of age, but mostly related to the presence of an HRR mutation. And survival is still immature in this study too. The hazard ratio is 0.94, even for the HR positive patients, and we expect again updated results over time. One of the reasons that MAGNITUDE may have failed in its efficacy in non-HR patients could be related to the toxicities. We do see a higher proportion of grade 3/4 treatment-related or treatment-emergent AEs, and this was largely due to more severe anemia. Again, about a third of patients required transfusions, more thrombocytopenia. So even though a dose reduction was needed for niraparib at 200, this did lead to higher toxicities comparing across trials that may have limited the efficacy of this combination. So just some speculative slides here about why was PROPEL positive overall and in HR BRCA2 subgroups, and why was MAGNITUDE only selectively positive in BRCA2 patients. This could be due to study design differences in patient populations. There are subtle differences where MAGNITUDE did allow prior AR therapy, but that was only 5%, and prior exposure to ABI for up to 4 months. That could have selected for patients who were less sensitive to ABI if an investigator put a patient on who was not responding as well to ABI, and that could have led to some bias. Number two, which I think is more likely, is differences in toxicity that may have led to subtherapeutic niraparib dosing. And even though there was more toxicity, this could have led to differential efficacy based on the doses that were chosen. This could be related to off-target effects, as I showed you in earlier slides, differences in PARP trapping as well, and pharmacodynamic comparisons. There's really no head-to-head studies, but clearly the hazard ratios in all subgroups, as I show here, favor olaparib, suggesting these are really different drugs. A major issue for both trials is that we're using more and more of these AR therapies earlier in hormone-sensitive and non-metastatic CRPC based on improved survival. This is from ARCHES, TITAN, ENZAMET, STAMPEDE, and LATITUDE, as well as ARASENS trial. And so one question is whether these trials are even relevant in this post-AR therapy setting. We do know that still about 55% of men in the community are still not receiving treatment intensification in the metastatic hormone-sensitive setting, although that's increasing over in the current eras. PROPEL did allow treatment intensification in the hormone-sensitive setting with docetaxel, so it's still relevant to those men. But in men who've already had a potent AR inhibitor, we need further data to support the use of PARP combinations, such as in the CASPAR study, before we start to extrapolate this to other settings. But moving these PARP inhibitors into the hormone-sensitive setting, to me, makes sense because that synergy of AR inhibition and PARP inhibition may be even greater before disease resistance mutations may take hold, as we've seen with docetaxel and with AR inhibitors. We do need more treatment intensification in this hormone-sensitive setting, as many of these patients will still pass away within a few years, and particularly patients with de novo and high-volume disease really have a major unmet need. It's really critical as you start to consider these combination approaches to monitor patients carefully for anemia, for hypertension, for cardiovascular risk, for survivorship education around diet and lifestyle, bone health monitoring, and in consideration of the toxicities, costs, and impact on quality of life as you're making these decisions. Thank you so much.